Welcome to this explainer. Today, we're taking the newly updated GINA 2025 guidelines and turning them into a practical, step-by-step clinical flight plan for managing acute asthma in the ED. If you're on the front lines of emergency care, nailing these exact steps isn't just a good idea, it is absolutely vital for saving lives. All right, let's jump straight into a massive paradigm shift. For the longest time, our gut instinct was just open the airways. But as this quote from the guidelines hits on, an asthma attack is massive inflammation, locked in with bronchospasm. So our core strategy right out of the gate has to hit both of these enemy fronts simultaneously. You really can't successfully treat one without the other. So here is our chronological timeline of care. We'll be covering the initial assessment, first-line immediate therapies, the 1-hour reassessment, refractory and ICU care, and finally, safe ED discharge. Let's kick things off with Section 1, the initial assessment. Right at minute 0, your standard ABCDE approach applies, and we literally cannot delay treatment. You need to instantly distinguish between severe and life-threatening. Now, severe asthma is the patient who's only speaking in fragmented words, sitting forward, maybe a heart rate over 120, and O2 SATs dipping below 92%. But life-threatening? That means their compensatory mechanisms are just failing. You're going to see exhaustion, confusion, poor respiratory effort, or outright cyanosis. Getting this distinction right dictates exactly how aggressive our immediate response needs to be. And that brings us to the terrifying reality of the silent chest. We're all trained to listen for a wheeze to diagnose an asthma attack, right? But in a truly life-threatening scenario, that airway obstruction is so massive and the respiratory effort is so incredibly fatigued that there is literally not enough air moving to even create a sound. So a quiet chest in an acute asthmatic, that is a massive clinical alarm bell. There's also this highly deceptive trap hidden in their blood gases. You might glance at a normal CO2 level on an ABG and think, hey, they're doing fine. But a normal or high PaCO2 is actually a huge red flag. Think about it. An acutely breathless patient should be blowing off CO2 by hyperventilating. If their CO2 is normal, it means they're tiring out, and respiratory failure is right around the corner. Moving right along to Section 2, first-line immediate therapies. Once we've gauged severity, it's time to deploy our chemical arsenal during that golden first hour. First up, oxygen, but with a major caveat. We only provide oxygen if the patient is actually hypoxemic. Look at these targets, 93 to 95% in adults and adolescents, and 94 to 98% for kids. We deliberately avoid slapping unnecessary high-flow oxygen on patients with normal SATs, because hyperoxia can actually make outcomes worse and drive up that dangerous CO2 retention we were just talking about. Next, we go after the bronchospasm. We hit them with a short-acting beta agonist, usually salbutamol. You're looking at 2.5 to 5 milligrams via neb, or 4 to 10 puffs via an inhaler with a spacer. And you repeat this every 20 minutes for the first hour. Now, if the attack is severe or they're just not responding, we immediately add 0.5 milligrams of nebulized ipratropium. Putting these two together significantly boosts bronchodilation and seriously cuts down the ultimate risk of hospitalization. Here's the really crucial point. Systemic corticosteroids absolutely must be given within the very first hour to shut down that inflammatory cascade we mentioned earlier. For adults, you're typically giving 40 to 50 milligrams of oral prednisolone or 40 to 80 milligrams of IV methylprednisolone if they can't take PO meds. For the kids, it's 1 to 2 milligrams per kilogram of prednisolone. The takeaway here? Give this early. Do not sit around waiting to see if the bronchodilators work first. All right, that brings us to Section 3, the 1-hour reassessment. We've hit the climax of our timeline. That golden hour is up. We've pushed the oxygen, the repeated bronchodilators, the steroids. Now we have to look at the patient and ask ourselves, did all that immediate treatment actually work? To find out, you need to rapidly run through these 4 reassessment steps to gauge exactly where their clinical trajectory is heading. First, check if their symptoms have eased. Second, look closely at their physical respiratory effort. Third, see if their oxygen SATs are holding up without support. And finally, if they're able, measure their peak expiratory flow, or FEV1. This reassessment basically creates a definitive fork in the road. A good response means symptoms are better, their peak flow is back above 60 to 80%, and they're holding stable for 3 to 4 hours after that last bronchodilator. Those folks are on the glide path to discharge. But a poor response, where that peak flow is stubbornly under 50%, dyspnea is severe, and you're seeing increasing fatigue, that means your patient is rapidly deteriorating and heading straight for the danger zone. Which leads us to Section 4, refractory and ICU care. For patients stuck on that poor response pathway, we have to escalate immediately. When the initial therapies fail and lung function drops below 25 to 30%, IV magnesium sulfate is our go-to heavy hitter. We give 2 grams IV over 20 minutes for adults. It acts to forcefully induce smooth muscle relaxation in the airways. Essentially, it buys us critical time when the standard bronchodilators just aren't breaking the spasm. Now, this is super important because there are still lingering myths out there about throwing the kitchen sink at these patients. But GINA explicitly advises against the routine use of epinephrine, unless there's associated anaphylaxis or angioedema. Same goes for antibiotics. Do not give them routinely. Unless you have rock-solid evidence of a bacterial infection, like pneumonia with a fever and purulent sputum, antibiotics have absolutely zero role in an acute asthma attack. We also really need to know when to call for backup. If you're seeing exhaustion, an altered mental state, a rise in PaCO2, persistent hypoxemia, or that dreaded silent chest we talked about, your maximal ED therapy has failed. At this point, ICU admission is absolutely mandatory, and you need to start preparing for potential advanced airway management. But here is a huge critical warning for you. Because asthma patients are incredibly difficult to ventilate, mostly due to trapped air in their lungs, we try to avoid intubation at all costs. It is a last resort. However, if you are forced into it by respiratory arrest or severe acidosis, your ventilation strategy has to be highly tailored. We use a low respiratory rate with a long expiratory time to let all that trapped air escape, avoiding dynamic hyperinflation or auto-PEEP, which can literally be fatal. Finally, let's wrap up with Section 5, Safe ED Discharge. For those patients who responded beautifully in that first hour, how do we safely transition them out of the ED? Well, before anyone walks out the door, this 5-step GINA checklist makes sure they've truly recovered. Their symptoms must be controlled. Peak flow has to be greater than 60 to 80%. You absolutely must physically check their inhaler technique because honestly, poor technique is often why they ended up here in the first place. You need to hand them a written action plan, and finally, you must start or optimize their inhaled corticosteroid therapy. And discharging them, that isn't the end of our responsibility. Strict follow-up within a few days is essential. Ensuring they have ongoing inhaled corticosteroids is completely non-negotiable if we want to suppress that lingering inflammation and prevent future exacerbations. Look, an ED visit is a glaring sign of failing chronic control, and we have to reset that baseline. Surviving the ED is definitely a victory for the clinical team, but it leaves us with this provocative final thought. An asthma exacerbation severe enough to warrant an emergency visit represents a massive failure in outpatient management. So if a patient ends up in the ED fighting for breath, are our preventative systems and patient education failing them before they even arrive? Thanks for joining me on this explainer, and definitely keep these guidelines close the next time a patient rolls through those doors.